Good morning. Calling the meeting to order. Board of Pharmacy General Board Meeting. We can start out by establishment of quorum. Ryan, do you want to start?
Ryan Brooks, public member.
Ricardo Sanchez, public member.
Victor Law, licensee member.
Amy Gutierrez, licensee member.
Albert Wong, professional member.
You forgot.
Oh, go ahead, I'm sorry.
That's okay.
It's A before.
Greg Lippy, public member. And it's nice to almost see all of you today.
Amjad Khan, public member.
All right, we move on to public comments for items that are not on the agenda or agenda items for future meetings. Good morning, Stan. Down on the green button, and you got to hold it.
Got it. Good morning. Stan Goldenberg, pharmacist, past member of the Board of Pharmacy. A few weeks ago, I was at a conference at USC talking about the future of pharmacy, and it was brought to my attention by several people the challenge that an independent pharmacy has now in obtaining a Medi-Cal permit. There was a moratorium, but that moratorium increased significantly to having no Medi-Cal permits being given to any pharmacy in Los Angeles. In addition to that, if a pharmacy has to sell, they cannot transfer their Medi-Cal. New pharmacies are also being told by the PBMs that if they don't have a Medi-Cal license, that they can't belong to a PBM. In essence, it has eliminated the independent practice of pharmacy. There's an exclusion from my understanding that the large chains do not come underneath this umbrella. I know that the Board of Pharmacy does not directly affect the interactions of Medi-Cal and the state, but I was hoping that the board would consider putting this on the agenda of the licensing committee to try to get an understanding. In my opinion, the care of the consumer can be challenged by having only 3 basic pharmacies to go to, as opposed to an independent pharmacy. And it seems to me, for new graduates or for any pharmacist that wants to go into business, this restriction eliminates that. And I was hoping that the board would possibly consider shining a light on this problem so that it can get resolved as soon as possible. On a second note, on a personal basis, I keep reading about the success of the 50-year program that the board has done. And my turn's coming up pretty soon. So I thank you for continuing the program. I look forward to being in front of you, accepting this, and I thank you all for doing a great job. Thank you very much.
Thank you, Stan. Good morning. Richard, can you push the button, the green button there, and you need to keep holding it. Keep pushing the button. There you go.
Oh, okay, I'm sorry.
Hold that.
Oh, that's the one. I was pressing the green button. Richard Fond, licensee for over 50 years, and had been honored by the board as such. I have gotten involved in an issue that's come to me because of my experience in my life about opioid addiction. I passed out a number of pieces that I've written and to the board for your consideration to disseminate in any way possible to the greater licensees of the board, my colleagues and fellow pharmacists. I had surgery in December, and I developed withdrawal symptoms from the use of a Percocet within a week's period of time. I had shivers and nausea and temperature fluctuations and other withdrawal symptoms after just a week of taking Percocet. And earlier in my life, in my marriage, my wife was in hospice care, and she was terminal. And while taking morphine and also on the Duragesic or fentanyl patch, the hospice nurse came in and administered and figured out she needed 7 times the dose of fentanyl that she was taking, and she was dead within 8 hours. So I've experienced symptoms of addiction, and I've also experienced the loss of a loved one from the opiates. So in this way, I feel that I'm a spokesman for both of those, which are major problems in our society today, as 64,000 people died of opiate addiction in 2016. The purpose, as I said again, is to request the board to disseminate information, possibly my statement, which is a personal experience statement in which I've talked to the dean at USC School of Pharmacy, and he wants me to speak to the students at the university, the class of the School of Pharmacy, and also be a part of a program that the School of Pharmacy at USC is initiating and proposed to present before the general student body. So maybe my personal statement, which has impact more than statistics, as a pharmacy student has written in the back of one of these pages at board, can be used in the script or in some way to disseminate information to raise awareness to the problem that exists in our society today, and I think that would be helpful. So that is my statement, and I appreciate whatever the board can do to expedite that. Thank you.
Thank you. Any more public comment? Okay, otherwise we'll move on to agenda item number 3, discussion and consideration of board approval of a training program for a designated representative. So Business and Professions Code, section 4022.6 establishes the definition of a designated representative reverse distributor. In Business and Professions Code 4053.2, the licensing requirements are defined for this designated representative reverse distributor. With the enactment of Senate Bill 752, it was effective January 1st of this year, the board is required to issue a license to individuals who qualify as a designated representative reverse distributor. Staff is working with the department to implement this license type in the board's licensing database, and the application was made available on the board's website on March 1st of this year. One of the licensing requirements for this license requires that an individual complete a training program approved by the board. So to date, there have been no board-approved training programs. Today, the board has a request from Skills Plus Incorporated to provide an approved designated representative reverse distributor training program. The program content has been reviewed by Janice Dang, supervising inspector. Due to proprietary concerns, the actual content is not being disclosed by Skills Plus Incorporated, but Dr. Dang has reviewed it and has worked with the organization on the content. I think there's a table of contents in terms of the class of sequence by laws and regulations referenced, as well as the content of what is required in this training program. So there's approximately 7.25 hours of training, and there's a final examination of approximately 90 to 100 questions. So today, the board is being asked to approve the designated representative distributor training program offered by Skills Plus for a period of 5 years and require Skills Plus Incorporated to submit annual updates regarding the content of the training plan that has been reviewed by a supervising inspector. Board comments.
Amy, are we being asked to consider this an exclusive, or anybody can do this? I mean,
My understanding is anyone can. This is just the first one we received. Is that right, Jenny?
okay.
I think there'll be others that'll come, I'm sure, come up, but this is the first one we received. So this will at least allow individuals to take some class. Jenny, do we know the cost of this program?
No, we have for all drug wholesalers, there's a requirement that they have specified training, and in fact, some of the requirements are similar for designated reps for the wholesalers that do the downward distribution from the manufacturer through the wholesaler down to the pharmacy or practitioner level. So this particular company, I believe, also trains other designated reps for other purposes, but we needed a training program in place so that the one license there's one party out there that's very interested in doing drug disposal in California, and without having appropriate designated reps, their only alternative to operating the plant is to hire a pharmacist.
Do we have any prescribed criteria for other organizations to develop programs too, or?
My guess
or-
is that with Dr. Dang's work with this particular firm, you can see the parameters behind. There's 3 pages of subjects that are going to be covered in that 8-hour course. So the focus there is aimed on covering those subjects. And so I think indirectly there's kind of a content outline, if you will, for what the requirements would be of the training class that the board did
So
participate in.
if you look, Greg, on attachment 1, I think any organization could come before us and say they're going to offer the items that are listed on these, 5 or 6 pages, and probably get the same licensing, the
Let's hope.
same approval.
Yeah.
But Ginny, what's the cost of this program?
I don't know. I have no idea.
Are we talking
I'm not
about
sure.
hundreds or thousands, or?
I doubt that it would be thousands, but I don't know. But the program, we've had one course provider that's been out there for a long time, God, probably 15 years, training designated reps. And there's only one. There's not a lot of demand, I don't think, to become a designated rep, such as there is, for example, for pharmacy technicians.
Any other board comments?
Is this information going to be put on the website, on the board website for the individuals to enroll?
It can be. We don't advertise the name of the provider. Somehow or another, they find each other. My guess is that the wholesalers that are interested in hiring these individuals refer them to the appropriate location where they can secure the training they need, in addition to the year of experience.
Okay, well, I'll make a motion to approve the program.
Second? Second by Ricardo. Any other board comments? Public comments? Good morning. I think you need to push down on the green and keep pushing while you're speaking.
While I'm speaking? Is that... First of all, good morning. California State Board and guests, thank you for the time here. My name is Bob Shaw. I am the president of Medical Waste Services. I am basically an old, grizzled garbage man that has been in the environmental industry since 1973 and in the regulated medical waste business since 1987. Thank you, Virginia, and your fellow State Board of Pharmacy members and Senator Stone for introducing and encouraging the passing of SB 752. Your leadership to help create a pathway for the environmental safe and local disposal of end-user pharmaceuticals is certainly applauded. I believe we all share the belief that pharmaceuticals should be disposed of safely. They certainly should not be allowed to become part of any drug abuse story, not landfilled, not clandestinely disposed of in the ditch, flushed, or shipped across the nation for disposal, as they can now be safely and economically disposed of right here in Southern California. Our company, MWS, is only a few months away now from that reality. We at MWS have created, permitted, and operated an incineration replacement technology locally, the Coronalux. Here in the South Coast Air Quality Management District, the toughest air quality district in the world. We've operated it now for 3 years. We believe it's the cleanest technology in the world for the destruction of pharmaceutical waste, and we are currently planning to permit and build a farm of at least 3 more Coronaluxes in Northern California. Skills Plus, I don't know where they are. You have certainly done an excellent, thorough job of designing a designated representative reverse distribution training program. What concerns us is that we are a disposal-only facility. Under the 3 requirements in 4053.2, designated representative reverse distributor licensing requirements, we will qualify via sentence 2B as, I'll read it now, we have a minimum of 1 year of paid work experience in the destruction of outdated and non-saleable dangerous drugs or dangerous device pharmaceutical waste. We don't employ pharmacists. We are not a pharmaceutical distributor or wholesaler. We do not want or plan to be anything pharma other than pure disposal. We are a pure destruction-only facility for non-RCRA pharmaceuticals, and hopefully with California State Board approval of pharmacy permits and then DEA blessings, we will soon be able to dispose of end-user pharmaceuticals in California that now must be shipped out of state. We will collect, receive, securely store, and then dispose of sealed boxes and containers full of end-user pharmaceuticals. We cannot open, count, or inventory via DEA rules any of these items upon arrival. We simply store them and place them in secure containers in the Coronalux for destruction. Thus, a number of suggested training items do not appear to relate to our pure destruction facility. A few random examples of proposed classes. 9.1, scheduled sales, losses, samples, shipping. 9.1, ARCOS items, automation of reports and consolidated order systems. 7.2, USP expiration dates. 6.1, who may order dangerous drugs and devices. 9.2, prescription rules, illegal acts, and the list goes on, et cetera, et cetera. Counting, tracking, and securing the containers we collect or receive before destruction are clearly understood. An understanding of the rules and penalties of not following California Pharma and DEA procedures for controlled substance should obviously also be understood. Again, operationally, we simply receive, secure, count, track, and dispose of sealed barcode containers. We have no idea what is in them. We simply destroy what enters our facility. What's left is zero carbon ash. Can our designated representative training program for the disposal-only facility more closely reflect what we do? I thank you for the time.
Thank you.
I will provide some comment. Part of what the federal law requires and our regulations require in order for you to be able to dispose of the drugs that you collect for incineration require that you be, one, licensed as a wholesaler, and two, specifically be a reverse distributor within that category. So what you are having to do is to, in part, have one staff person that oversees the facility that would be knowledgeable about the downward distribution of these drugs, in part to impart the care and the tracking and the other elements that are so vital to why pharmaceuticals in the U.S. are the gold standard worldwide. And accordingly, because you're going to be in a very trusted place where the drugs that are picked up could easily re-enter the drug supply if not handled appropriately, we want your employees, and especially the ones in charge of your plant, to have some skin in the game. So accordingly, we expect this training program, which is modeled in part after the designated reps for drug wholesalers in general, to provide your employees with the same general training with a special element for the disposal side that we'd expect of any drug wholesaler. Because, in part, we initially envisioned that some of the designated reps that end up working in your plants could have started on the, downward distribution side of wholesaling. So hence, a knowledge of the understanding of how the marketplace operates, what the relevant laws are for the downward distribution, in hopes of also providing some appreciation and knowledge for what they're dealing with, and some of the discussions you may have as you pick up the collection of, heaven only knows, pharmaceutical waste from pharmacies and skilled nursing homes.
Thank you. I think I understand that issue. Again, we don't count, look, we don't even get to look at this material. It simply arrives in a sealed container that has a seal on it. We inventory that and store it. So all of the other drug handling rules and regulations just don't seem to fit our space. I mean, I understand the diversion concerns. All of that is certainly necessary. We were just hoping to cut the training down to 4 hours. I'll have to train numerous people. I have to have people on site 24 hours, so I just can't train one person. I have to have
Well,
numerous
the
people
current
to-
training's only 7.25 hours, so 3 hours difference, is that the issue on the training side?
No, now, I'm a grizzled garbage guy, as I said. I mean, it looks like you're trying to make us a pharmacist. All we're really trying to do is just dispose of the waste.
I can tell you, the pharmacist training would be a lot more than 7 hours.
I was going to suggest that myself.
All right, well, thank you for your time.
Thank you. Any other public comments? Good morning.
Right.
Hold the,
How's this? Everybody can hear me now? Hi, I'm Holly Strom. I've got my entire back to the audience. And I'm a former board member of the California Board of Pharmacy. And I've been working with Bob, encouraging him, telling him not to give up, and explaining the board's process to Bob. So I'm in full support of what he's doing. I'm on the Safe Med LA Opioid Safety Coalition for Los Angeles County. And part of our charge is to ensure the safe and appropriate removal and destruction of controlled drugs so they don't re-enter the street supply. One thing I noted when I was going through the training list of all the requirements, it's page 7 of my, when I look at it as a PDF on attachment 1, they have listed there under personnel the designated representative qualifications, and it ends at 4053.1. So this new license category is 4053.2. I don't know if that was an oversight or whether they just assumed that because this particular license category is the one that's being covered. Do you all see what I'm talking about? It's in that, that long list of sections, law sections, and when I look at it, it's page 7
are you
of
talking
12.
the flow of the class?
Yes. the long list that has all those code
Where-
sections.
Right
And
here, this is what she's talking about, right here.
so when I look at it, it's 7 of 12.
Yeah. Yeah, probably, I agree.
It looks like a typo.
Well, I mean, there is a 405.3 and there is a 405.3.1, but the new license category is 405.3.2, and they don't have that on here. So I don't know if that is something that they left out. This is the license category that Bob is interested in applying for. So, you know, I mean,
Can
they
we
should
ask-
know what's required of their own license category, right? I know Bob does because he's,
We'll ask Dr. Dang to review that with the course.
okay, yeah, just have
material.
her have a look at it.
My supposition is in fact, as Dr. Gutierrez stated, and it is probably a typo, because I think it doesn't make any sense to talk about general in this particular case, where you don't talk about the specific duties allocated to a designated rep as a reverse distributor. So I agree with you on that.
Okay, thanks, everybody.
Thank you. Any other
I was going to say, so if the board would like to ensure that that happens, it could modify the motion to basically have Dr. Dang review it to ensure that the correct code section is addressed, and then
Are
authorize.
you okay with amending the
Authorize.
motion?
Motion is hereby modified.
Ricardo? Yes? Okay.
So I think you need to say it out loud. Right,
For Dr. Dang to review that.
correct.
Is that right, Greg?
So,
Any other public comment? Otherwise, all in motion, raise your hand. All in approval, sorry, raise your hand. Okay, unanimous. Moving on to the next item. Discussion and consideration of proposed regulations to amend Title 16, California Code of Regulations, Section 1746.3, related to the naloxone fact sheet. So CCR 1746.3 specifies the protocol requirements for pharmacists that furnish naloxone hydrochloride. Included is in the regulation is a requirement for a board-approved fact sheet that the pharmacist is required to give the patient upon furnishing naloxone. Business and Professions Code Section 4052.01 authorizes a pharmacist to furnish naloxone in accordance with the protocols that have been developed and approved by the board and the Medical Board of California. So this regulation, and what we're doing, I'm assuming, is we're requesting a modification of the regulation, Jenny, to allow the board's executive officer the authority to approve alternate fact sheet that contain the same content as the board's required fact sheet, but are formatted or presented in a different manner. Because currently, the regulation doesn't allow for that flexibility. Is that correct?
Correct. And it clarifies an issue where we were requested to approve an alternative form of a fact sheet, and it wasn't exactly the same. This provides the specificity to identify exactly what we expect to have in the fact sheets for naloxone. And it also allows the executive officer to approve it, so it doesn't need to come before the board.
So, and looking at attachment 1, just a question I had on the language that was, I think it's on page 2 of the proposed regulation, the last line under 6, under where it says fact sheet, and there's the modifications to the reg. It says fact sheets in alternate language must be the current naloxone fact sheet approved by the Board of Pharmacy. That seems a little, the language there, should be an equal translation or something of that, so that it's a little clearer of what that means? Because what you're doing with alternate language is you're doing a translation, right?
Yeah, the board already is translating into 5 different languages the naloxone fact sheets. What this would prevent is having to do, if you were doing your own equivalent form of the naloxone fact sheet, it would prevent you from having to translate that, and instead, people that do not speak English could obtain it in the languages that the board translated without the translation requirement on the individual requesting.
So what I'm referring to is just that the language just sounds a little, it's not clear to me what exactly we're saying. So fact sheets in alternate language must be the current naloxone fact sheet approved by the Board of Pharmacy. Sounds like there's something missing. So should it say, should be an equivalent translation, or should be the accurate translation? Something that's clear.
Isn't it saying, though, that they can't use the or a fact sheet approved by the executive officer for this purpose?
Right, it's saying in this particular case that the board translations are the ones that will be provided to the non-English speakers, that there is
Right.
no requirement for them to have to do the translation of their modified version of the fact sheet. The obligation to translate would still stay on the board.
Yeah,
So then what it's saying is they cannot do their own translations
Correct.
at all.
right, that's what it's saying, that they have to use the specific one that's there.
Okay. So motion to approve by Victor, and it's to approve the proposed modification to Title 16 CCR, Section 1746.3. I'm sorry, did you have a question? Okay, so basically the motion that's in the packet. Okay, so we have a motion by Victor, second by Cheryl. Any board comments? Public comment? All in favor? All right, moving on. Agenda item number 5, discussion and consideration of draft frequently asked questions, or FAQs, relating to the inventory reconciliation reports of controlled substances. And Title 16 CCR 1715.65, which is a new reg, requires that every pharmacy and every clinic that's licensed in the Business and Professions Code shall perform periodic inventory reconciliation functions to detect and prevent the loss of controlled substances. You may recall this is a C2 inventory reconciliation, where every quarter they're required to count and reconcile essentially their checkbook on whether they have a loss of C2 drugs. So there's a copy of the regulation timeline in your packet. This regulation will become effective on April 1st, 2018. In an effort to assist the licensees to comply, an FAQ document was prepared by board staff, and a copy of it is attached for our review. I had a question on page 4, under the hospital, under the Q, I think it's the bottom of page 3. Does an inpatient hospital pharmacy or any pharmacy that services on-site or off-site automated drug delivery systems have to complete an inventory reconciliation report for Schedule 2 controlled substances contained within the ADDS? And it says, no, there's no quarterly reconciliation report required. But if you go on to the next page, it says in bold, the pharmacy's transfer of stock to an ADDS. I'm just wondering if we should clarify it to an off-site ADDS. Would be reflected as a disposition in the pharmacy's reconciliation report. Because on one hand, we're telling them they don't need to do it, but then on the next hand, 'cause I think maybe just the word off-site is missing there.
I think it's the regulation in subsection H requires that the PIC of an inpatient hospital or pharmacy servicing on-site or off-site automated drug delivery system shall ensure that.
So the transfer of stock wouldn't happen to an on-site, right? Or would be reflected as a disposition in the pharmacy's reconciliation report. So they're not doing a reconciliation report for on-site, right?
For the on-site machines, no, they don't have to do that.
So
But they have to have security systems in place. But the pharmacy that puts the drugs into the machine, that would be a disposition coming out of the pharmacy stock.
Right, no, I think I'm in agreement. I'm just saying that should we clarify that the transfer of stock to an off-site ADDS would be reflected as a disposition in the pharmacy's reconciliation report? Because an on-site one wouldn't require a reconciliation report, right? Because ADDS is very encompassing. It's both on-site and off-site.
I think our attorneys think.
Yeah, I think what we're talking about, I think what we're trying to capture is that even though the ADDS, the drugs in the ADDS aren't being reconciled, because they're not being reconciled, once you take them from the primary pharmacy stock, there has to be an accounting of it leaving the pharmacy stock, and that is going to be captured on an inventory reconciliation report.
So then there would be a reconciliation report required for on-site?
For the pharmacy, I think. So it's.
Pharmacy tracks it to the machine, and that's where it stops. Sorry, is this positioned to the machine? I know somebody was waving at me. Sorry, Lou.
So we start off by
Because the
saying that there's
ADDS.
no reconciliation report required for an ADDS machine that's operated by a pharmacy. But then we go on to say that the transfer of stock to an ADDS would be reflected in the pharmacy's reconciliation report. So
The important part being there, it's the pharmacies. So the pharmacy is reconciling the drugs that are in non-ADDS stock. And if they don't account for its removal from the non-ADDS, then they're going to have an overage.
But this does say to an ADDS, though. That's the line in bold says that.
Right. The focus really is on the removal from the primary pharmacy's stock, as opposed to, and the pharmacy's inventory reconciliation report over their inventory that's not in the ADDS machine.
Okay, I'm still confused with this. I don't think it's clear.
So if,
May I suggest, unless other board members are concerned about this, that Laura and I and Dr. Gutierrez work together to see if we can resolve the wording of this particular FAQ so that it's more meaningful, so that we're not creating a conflict or some kind of confusion.
Yeah, because I think there's a difference between an inpatient hospital where you're having machines that are inside the hospital premises. You're doing transfers all the time or restocking those every day, multiple times a day. And there's a difference between a machine that's located off-site, which is what a lot of this real inventory reconciliation is kind of focused on. So I just want to make sure we're clear and the hospitals know what actually is expected of them. Well, that's fine, Jenny.
I have a comment on the page 1 of 2 order of adoption. Paragraph C4. All records used to compile each inventory reconciliation report shall be maintained in the pharmacy or clinic for at least 3 years in a readily retrievable form. Many of our cases don't even get to us till 4 or 5 years down the road. I think 3 years is too short to retain the records.
That would trigger the readoption of the regulation. Almost all of our records are required throughout our code as 3 years.
That doesn't mean they're right.
Your suggestion is a very all-encompassing and a major revision of pharmacy law in general.
Keep in mind, I have an audit background.
You want 7 years, 12 years?
I'd like 5, but it sounds like it's something that we can't do, so I will.
In all seriousness, if you would like to consider that, we'll put it on an agenda and have a discussion. We're moving towards electronic records anyway.
Right,
It's a lot easier with electronic records to keep longer history.
exactly. So, well, let's bring it up for discussion.
We'll put it on a future agenda item.
Thank you.
Any other board comments? Victor?
Okay, let me put a hypothetical situation here. So if I order 100 Norco 10, so 3 months later, I found out that I only got 95 left. I'm short of 5. So should I report to the board in 30 days? And I cannot account for the 5 missing tablet, all right? And then what happened that 3 months? Should I use the baseline as 5 negative, or should I start off and say, I report to you that I'm missing 5, and I should start off back on the regular 0? I mean, it could add up every 3 months, when you keep losing 5 tablets each time.
Well, your new inventory reconciliation report, after you report your losses or your overages to the board, would become your new baseline for the future. So you would basically adjust it once you hit the 95 and not the 100 that you expected. What we would expect from you is to determine where those 5 pills could have gone, and if you can't determine with certainty, possible causes and then steps you're taking to make sure that you don't lose another 5 or 50 in the next quarter. So that you're maybe going to count daily, or you're maybe going to put them in a more secure location under only your control. something that you would do that would make sure that there wouldn't be a future loss, because the whole purpose of this reg is to get you to count and identify sooner, at the earliest possible time, that a loss has occurred, and then take steps to prevent future losses. So that's why that mitigation of whatever you've done to address the loss is so important.
And this FAQ is in an attempt to help licensees understand this new regulation and improve compliance. And it's really more of an education piece that we can actually add to and modify. I think it's a good idea that we adopt this whenever a new regulation that's this major, this change, actually is put in place. Public comment. Good morning, Lauren.
Good morning. Lauren Paul, Senior Director of Pharmacy Regulatory Affairs for CVS Health. I wanted to take a minute and just come up and thank the board staff for putting together these FAQs. I know this regulation was a long time in the making. There's been a lot of discussion around it. And I think there was some confusion that came out when the script article came out, and this definitely helps to clarify some of that. I specifically have a couple FAQs that I wanted to address. First of all, I want to thank on page 2 the questions regarding the clarification that this only requires the inventory reconciliation report for Schedule 2s every quarter and does not include all controlled substances.
So which question is this, Lauren? It's on page 2?
It's on page 2. It's the second and the fourth question. It's really just the clarification that this applies to Schedule 2s that need the physical count every quarter and not all controlled substances. We do appreciate the clarification there. On the next page, page 3, for the first question and the second question regarding perpetual inventory, I think there still needs to be some additional discussion about this. I know that perpetual inventory has been talked about in the previous rule hearings and throughout this regulation. But the essence of how a perpetual inventory works is you do receive all your acquisitions, the dispositions, and then you are doing blind counts in many cases as you're dispensing that medication. So you're matching up your physical count to your inventory count, and you are doing a system where you're able to identify any losses much earlier than 3 months. So we would ask the board and the board staff to possibly consider rethinking whether a perpetual inventory system or possibly if you need an additional demonstration of how, I will say, ours works for our community pharmacies, because we feel that we're able to identify any issues on a much sooner basis than quarterly. For the next question, I would move to page 4. It is the second question about halfway down, where it talks about must be compiled at least every 3 months. There has been discussion of maybe a 7-day leeway if you don't hit that exact 3-month mark. Just based on scheduling of a pharmacy, it might be that third month day falls on a Monday. Nobody's going to want to do this on a Monday. There might not be the ability to do it earlier. So if there's maybe a 7-day leeway after that, that was a question that has come up that's been asked as we discuss this. And then finally on page 5, the very last question around paper documents and electronic records. We appreciate that electronic records are acceptable to keep this. The question has come up as what is the definition of readily retrievable? Is it when an inspector is in the pharmacy, they have to retrieve that information real time? Or is there, a 72-hour allowance for that readily retrievable information? Those are just some clarification points that we've asked regarding the FAQs.
Thank you. I think there's some good questions in there that we should probably consider. Now, if perpetual inventory system does do the physical count, as Lauren stated, could we allow that to satisfy the requirements of the regulation as long as a physical count is performed at least once every quarter?
They have to still reconcile it, even though they have to still reconcile to make sure that it makes sense. In the physical count, we spent a lot of time discussing how to present this. Part of the problem is we do not have a definition of what a perpetual inventory is to the board. Everyone's got an idea of what a perpetual inventory is, But we're not certain. When we talked to a couple of different entities, they both said different things about what a perpetual inventory is and how it's calculated. And accordingly, if the board wants to go to that level, I think that we probably need to do a regulation to define perpetual inventory for purposes of this regulation.
Right.
So that
Many,
there's no-
many perpetual inventory systems, they do the cycle counts and so on, like she's talking about. And if that is the case, then it probably should be okay. However, many of the systems don't do that. So it has to be specific that it would be a system that does provide for that. And I thought that I read something in here that talks about that in one of the other FAQs that says if they are actually doing a count along with the perpetual, then it would be okay, but I can't find it now. So,
Part of the objective to the regulation is for the C2s that there be a physical count done during that quarter that is actually reconciled. So it's the dependent on how it's reconciled, whether or not that hard count counts.
yeah, the issue with perpetuals, believe it or not, they're easy to make adjustments to. And so without the physical count, you cannot rely on the perpetual. But if it does include counts, then that's another story, so.
Well,
So
the
Greg, if you have, let's say you have 10 drugs, and you're doing cycle counts, but they're not all on the same day. So your cycle counts that is facilitated by perpetual inventory, maybe you do one a day for 10 days. You're essentially doing the same thing, except it's not at one time and in one report.
Correct.
Except you're pulling those reconciliation dispositions for all 10 of those drugs every single day because if you've got multiple acquisitions coming in from a wholesaler, for example, where 2 of the drugs that you would normally count on Wednesday and Sunday, let's say, you're still going to have to count it on Wednesday and Sunday, depending on which drug it is. The
Yeah,
other
I
thing,
think the question is how long of a period of time goes by before you find out that there's a problem.
and that's why every quarter, every single C2 is going to have to be hand counted, even if you don't dispense it. In the unlikely event that you've got an inventory, a bottle sitting on the shelf that you haven't touched in 90 days, you still have to physically count it.
What about the comment about definition of readily retrievable? Is there a way to define that, or?
Correct. What we find, and part of the reason we use the word readily retrievable, we walk into a pharmacy, ask for records, and nobody's there that can provide them to us for whatever reason. They can't access the system, they can't provide records. So we'll amplify that, and we will punch that particular area of this up a little bit about what we mean.
Thank you. Any other board comments? Any other public comments? Good morning. Yeah.
Can you hear me?
Bush.
Okay. Hi. Ketan Patel with Kaiser Permanente, pharmacist. Once again, echoing the remarks from earlier. Thank you for this FAQ. I think it's important that we, with the change as big as this, we consider the licensees and sort of adoption. It's clear that the board is really trying to help provide clarity for licensees. So certainly appreciate that. One comment I have is on page 2, the second FAQ. We point to the differences between state and federal controlled substance schedules. Do we have a reference that the board can possibly provide or a link to key differences between California and federal so that, that's a little bit more clear for folks out there?
Well, we have one. Doesn't Kaiser?
Yeah, we do, but I'm just speaking on behalf
Sorry, I
of,
couldn't resist. I'm sorry, I couldn't resist.
Yeah, no problem. It's the shaved head, I know.
That was
Yeah.
an unnecessary comment. Let me figure out. We'll put it on violence in the workplace.
It was just,
Where's that security guard, by the way? We will go ahead and we can put it online. There are a few things, some barbiturates in California that are make it scheduled in California, not federally. A few other things. The more active, vital schedules right now are really those that the federal government has done. But California still has a few, and we have a bill going through the legislature this year that's going to force
Clean
us
that
to
up.
have to rectify between the schedules somehow. And I have a feeling this issue is going to become forced on us one way or the other. We might as well put it out there.
yeah, I'd agree. And then I'd just like to echo the remarks about the on-site, off-site comments. Very important, I think, that if we could provide some clarity there, that would be very good. And then, of course, the perpetual inventory comments as well. Thanks.
Thank you. Good morning, Danny.
Good morning, Danny Martinez with the California Pharmacists Association. Good morning to everyone. Thank you for these FAQs. I know that CPHA has received a lot of comments on this regulation, and so I've been trying to collect them all as fast as I can. I'm not going to go over each of the 1,500 or so emails that I've gotten on this, but one of the main points that we really wanted to address is active enforcement. So, the very first FAQ is very, very helpful when you explain that the board expects pharmacies and clinics to transition. What I'd like to see if I can get further clarification on is not necessarily a specific date, but more of a range in what the board expects pharmacies to start complying with this. So are we talking weeks, months after April 1st, that kind of thing?
I think that's the first FAQ, right?
Right.
Generally, with a major reg, it's 6 months of educational compliance.
Okay.
And this is a pretty major reg.
Right.
What we want to do, though, is to have that initial inventory of all C2s being conducted as soon as possible, or when there's a new PIC.
Okay.
And consequently, that will be a phased-in approach, because we don't want people to just start counting and not know where they're going with this. We want them to literally do their policies and procedures, figure out the process by which they're going to undertake this, because many pharmacies are already doing this.
Right.
And then move forward with it. If after 6 months we start encountering a problem where pharmacies haven't implemented, we are going to do something. We'll probably bring it back to the board. But we expect pharmacies to transition to this. We think this is an asset for the pharmacy, and it's also a real serious health problem. So we don't want to wait a year, 2 years,
Correct.
3 years to vigorously enforce this. We just want, and we will for the next 6 months, educate our way into this, and then we'll figure out where we stand.
Right, and I think kind of what our members are worried about is having this regulation be implemented, and then all of a sudden on their first attempt have an inspector come in and start dinging them for whatever. And so that's helpful to read this and to hear that's sounds like that's not going to be the case. And so we just wanted to thank you a lot for that. And I echo the comments from earlier in terms of the C2, because there was a lot of confusion whether this had to be all drugs or just C2s in terms of reporting every 3 months. So we appreciate that. And we're going to be putting together a document for our members to help disseminate and further explain and clarify this. So thank you.
Dan, I'd also recommend that if there's a lot of questions, you're getting the same question, just submit it to Jenny so that we can at least, because we'll be amending this FAQ as questions come up, and it's probably as the inspectors go out on the field and start hearing more questions. So this is just the first attempt, but it can be updated.
Great, thank you.
But I would like to say that it's real important that you recognize, and that's part of why we provided a summary of section by section of the regulation, what it means. The first section of the bill does, or the regulation does require you to have a process in place to inventory and control all controlled drugs, not just C2s. But the counting requirement for the reconciliation piece here is only C2s.
Appreciate that clarification. Thank
And
you.
Jenny, this does not stop the requirement if an identified loss happens in C3 through 5, that it be reported as well.
Yes, exactly, within either 30 or 14 days, whichever.
Thank you. Any other public comment? So do we need to approve these, or these are just?
Well, we have one more.
Good morning, Norm.
Norman Willis, practicing pharmacist. I have a question regarding the quarterly count. Does this apply to outpatient surgery centers as well as other facilities?
If they are licensed with us, yes.
Excellent, thank you.
Any other public comment? Good morning.
Good morning. Can you hear me? Okay.
Yes.
Thank you again for the FAQ. So while we're currently implementing and revamping some of our processes to meet the new regulation, we actually have some additional clarifications. So from Cedars-Sinai Medical Center, and I apologize, I didn't introduce myself. I'm Naira Barsagian, practicing pharmacist. So one question that we had was regarding sections A and F. We wanted to know, is this related to inpatient pharmacies as well? So another question we had is, for community pharmacies that belong to GAG and manage ADMs in the clinics or AmCare areas, do they have to comply with H and G? And do we have to count the inventory and the PICSs? And I believe I heard earlier that this was something that was going to be discussed offline. So related to who needs to sign the reconciliation report, we actually do have a large quantity of people involved in the inventory process. It consists of 10 plus people. So what I wanted to know is, would we have to have every single individual sign the reconciliation report, or would it be sufficient for the finalizing pharmacist to sign the report? Another question.
Can I
Yes.
ask for your questions? It may be just in the better interest of getting the information. Could you submit those in writing, and then we can add them to the next amendment of the FAQ document?
Okay.
Will that work?
Yeah. And just the last question we had is a definition for pharmacy satellite location. So I could submit those questions to you as well.
Thank you.
Yeah. Okay. Thank you so much.
All right, so does anybody want to make the motion to approve the FAQs relating to inventory reconciliation? Greg, move. Victor, second.
Yeah.
Any other board member comments? Oh, and then we also want them to publish. We want to approve the FAQs and post the FAQs on the board's website and publish them in the next issue of the script. Any other public comments? All in favor?
Quick question, Amy. I'm assuming we're going to post the FAQs with a notice that these may be updated periodically.
That's a
right?
very
We'll-
good point.
Yeah.
We
With
should
little
put that at the end of the
asterisks.
FAQ, yeah.
Correct.
And just for clarification, I would also sort of pose to the board that normally this kind of thing doesn't necessarily require the board's approval. This is something that your executive officer would do in the course, so the updates wouldn't necessarily come to the board, or they don't need to come to the board.
Unless I believe they involve a policy issue that needs to come before the board.
Yeah, that's actually better
That's part of
because,
the reason we wanted to put these out in front of the board as a general policy.
but any updates, I mean, because that's, you don't want to have to wait for a board meeting to have to update them. Good point, Ryan. All right, moving on to agenda.
Yes, sound like this is very complicated for them to follow this regulation. So I would like to have a little grace period for them to implement it. So instead of hit them on the head when they, break the rule. So I'd like to see a little grace period before the inspector go after them.
Well, we're going
Actually,
to
there
do
is.
educational compliance for 6 months. Is that,
Yeah.
okay.
So the whole goal of this is to make sure we don't have these large volume C2 losses that we keep seeing on cases. Because if a pharmacy is reconciling every quarter, we should only see 3 months loss at the most, right? Okay, moving on to agenda item number 6, discussion and consideration of proposed regulations to amend Title 16 CCR and 1793.5 related to the pharmacy tech application, 1793.6 related to the pharmacy technician training requirements, and 1793.65 related to the pharmacy technician certification programs. So these are previously board-approved regulatory language that was sent for DCA review, and we're now, and Ginny, you want to go over, we're just combining them all into one now?
Right. We think that there's an efficiency involved in doing one rulemaking dealing with the pharmacy technician programs on essentially ministerial functions more than anything else, and then secondly, doing it as a single rulemaking instead of 3. The rulemakings are taking us a long time to get through the process, so we figured this is all dealing with technicians in a relatively straightforward manner. Let's just consolidate and move forward with them.
So the proposed motion is to approve the proposed modifications to these sections, to all three, and initiate the formal rulemaking process as a combined rulemaking.
Correct, although I would like to make a couple of recommendations.
Okay? What is your other recommendations?
One
The
of-
other one is delegating to the executive officer the authority, the common executive officer clause. What
Si-
else would you like to add?
Since we're at the front end of this, under 1793.5, the pharmacy technician application form 17A5 revised 1015, that 10/2016 should be stricken because we never released it. So instead, it just would go straight to 318. That, there was just a strikeout that sorry, this pushing down the button is a hard skill for me to get. Of course, if it was something else and I wasn't talking to the microphone, I'd have another excuse for that. 1793.65, the pharmacy technician certification programs approved by the board. This particular approval would run out December 31st, 2020. Given that the rulemaking process is taking us pretty much a year, start to finish, and we're at ground zero right now with start to finish, that would mean the absolute earliest this would take effect would be mid to late 2019. I would suggest we push that date back 1 year to 2021 to give the reg a little greater longevity.
Okay.
And it still keeps it close so that the board can re-review the components and keep it fresh.
So is that all, just two
Sounds
requests?
fine.
Yep, that's all I had in mind at this point.
Okay, is there a motion to approve the, moving forward with the rulemaking with those amendments?
So moved.
Okay, moved by Greg, second by Ryan. Any board comments? Any public comments? All those in favor? All right, well, we're done with the section on the regulatory business, so we'll move on. Let's take a 10-minute break to allow the hearing officer set up, and then we'll move forward with petitions for reinstatement of licensure.